Hello students, I am the OG Guru Dr. Punit Bhojani here with a single point agenda to make OBGY your most favorite subject, most scoring subject. And in this very important video, I am going to discuss the top 5 obstetrics topics which repeat every year, and you should do these 5 topics of obstetrics before you go for the FMGE Jan examination. So these are MCQs, they are very important, stay right till the very end. We are also going to discuss some very interesting images, clinical case scenarios, and do get in touch with me on phone and WhatsApp on this number. And before we proceed, download the OGGURU app, and 2 months rapid revision course has now been launched only at 679 rupees with free extension till your Jan 17th examination. It has got absolutely able to revise the entire OBGY in just 2 days time under my guidance. It is a MCQ based revision with also theory rapid revision, and PYQs will be covered not only of NEET PG, of also FMG and also IBQs, clinical case scenarios, everything will be covered. Okay, so get in touch with me on phone and WhatsApp if you have any difficulties and doubt, and let us begin. The first and the most important topic is the topic of malpresentation. By this, what I mean is mainly the questions come on breech and transverse lie. Mainly the transverse lie or the breech are the expected MCQs, and let us see what is this. So clinical image question, it's a IBQ. Some procedure is shown to you. Step number 1, please identify what is this procedure. And the question is, this procedure is not contraindicated in ABCD. So can you see what is this? Yes, sir, here the baby is in breech position and we are rotating the baby ulta pulta karke baby ko somersault, and finally we are making the baby into vertex or cephalic presentation. So this is the external cephalic version. Please comment in the chat box at what weeks of gestation will we do the ECV. Anybody, at what weeks of gestation should the ECV be attempted? 32, 36, 40, 42, what should be the answer? Okay, now, so the question is, what is not, this procedure is not contraindicated in. So now please understand this, that point number 1, first of all, why to do ECV? Okay, anybody, why do we do ECV? Yes sir, ECV is done for 2 purposes. Is one, that sir, because I want to avoid the breech ka vaginal delivery, because breech vaginal delivery there is a risk of complications. Okay, because when I try a breech delivery vaginally, there could be more complications. And second is, if it's a primary with breech and all that, I will have to land up doing LSCS. Is it clear? So the main reason why I want to do this is I will avoid doing LSCS. If from breech I make the baby into vertex, vaginal delivery is easy. So one is the complications of breech delivery. Complications of breech vaginal delivery is going to become lesser, and LSCS chance is also going to become lesser. But what are the contraindications for ECV? Twins. If there are 2 babies, okay, if there are 2 babies, we cannot do this. Similarly, if the membranes have already ruptured and all the liquor has drained out, or patient has already come to us in active labor and contractions. Similarly, one very important, if the liquor is very less, oligohydramnios. Okay, so it is very difficult to rotate the baby. And similarly, if it is very more liquor, polyhydramnios. So वहाँ पे क्या होगा? If it's polyhydramnios, you will rotate the baby. Baby will again rotate back. You will rotate, baby will again become breech. Okay, so you make breech to vertex, baby again done. So polyhydramnios में again the chance of failure is very less, is very high. Okay, so twin pregnancy, PROM, active labor, oligohydramnios, polyhydramnios, and now please pay attention. All of you look on the board. Suppose if this is the uterus and this is the placenta, we are having placenta previa. Now when it is placenta previa, बेबी प्लासेंटा फाड़ के बाहर तो नहीं आएगा, फटा प्लासेंटा निकला हीरो या हीरोइन. सो व्हेन इट्स प्लासेंटा प्रीविया, आई एम एनीवे, please understand, whether it is vertex or it is breech, Please understand this very important case, sir. Suppose it is breech and if it's a placenta previa, then also I have to do cesarean. And suppose if I rotate the baby, I rotate this baby and make it into kefal. What is the benefit? No benefit. In fact, we are doing the risk of ECV. What ECV also has its risk. Okay. So in placenta previa, anyway, the vaginal delivery is not possible. It's going to be torrential bleeding and baby cannot perforate through the placenta. So in placenta previa, anyway, we are going to do LSCS. Similarly, if there is no space for the baby to come out, there is contracted pelvis. Okay, contracted pelvis, or if you understand previous 2 LSCS, previous 3 LSCS, where anyway we are going to do LSCS. Is this understood to all of you, my dear students? Okay, sir, for whatever reasons, except previous 3 LSCS, previous 4 LSCS, contracted pelvis, placenta previa, all this become the contraindication. And lastly, remember, if it's a very precious pregnancy, okay, like patient has bad obstetric history, previous babies have died, then please don't do all this stunt, because while rotating the baby, there can be, of course, complications. So we don't want to do this stunt if it's a very precious pregnancy or like a IVF pregnancy. In such cases, also better we directly go ahead for LSCS only. So please understand this. Now you know, yes, sir, placenta previa, because VD is my short form. Vaginal delivery is not going to be possible. I anyway have to go and do LSCS. Multiple pregnancy, twins I told you, PROM also I told you, primi gravida is the answer. Yes sir, primi is not a contraindication. In fact, primi is a very good indication. Okay, primi gravida you would want, because otherwise primi with breech I'll end up doing LSCS. So primi gravida, ECV is not contraindicated. ECV should be attempted in primi gravida so that I can avoid complications of vaginal breech delivery and I can avoid LSCS. This is understood to all of you. So please keep in mind that wherever LSCS is going to be required, if LSCS is going to be required, like contracted pelvis, previous 2 LSCS, previous 3 LSCS, placenta previa, then we do not attempt a version or the version is contraindicated. And similarly, PROM, active labor, oligohydramnios, polyhydramnios, all these cases also we will not attempt a external cephalic version. So please comment in the chat box at what weeks of gestation ECV is done, and also if you can comment what are name 1 or 2 complications of ECV. What can happen while I'm rotating the baby? What all complications can happen? So this is a very important topic, external cephalic version. This image is very important. IBQ could also be asked to you. So with one question I have discussed 2 MCQs. The second short topic which is going to be asked to you is the topic of preeclampsia. Now let us see. 32 weeks pregnant lady, BP 170, 100, urine albumin +2. So this is basically preeclampsia. So high blood pressure, complains of also headache, oliguria, blurring of vision, no convulsions at present. Very good. That is given to you. What is the best management? Now can anybody tell me, by looking at this clinical case scenario, what is the diagnosis? Anybody? Is the diagnosis eclampsia? No. Why diagnosis is not eclampsia? Because sir, no convulsions present. No convulsion present diya hai, so it is not eclampsia. Is the diagnosis only preeclampsia? Is the diagnosis only preeclampsia? No. Can you better the diagnosis? Why not only? Yes sir, it is preeclampsia. Why? Because the BP is high and urine albumin is also present. So yes, it is preeclampsia, but can you better our diagnosis? Yes sir. Please see what is present. Headache, oliguria, blurring of vision. So this is impending eclampsia. That is my diagnosis. And what are these called as? So these are called as the 5 dangerous. They are called as the premonitory symptoms. And कैसे याद रखना है premonitory symptoms? OB easy है ना, मैं हूं ना, OG Guru है ना, तो O भी easy है ना. What is O? Oliguria given in the question. B is blurring of vision. E से होता है epigastric pain. H is headache. And N is nausea, vomiting. Okay, so these 5 please by heart. You should know this 5 by heart. Oliguria, blurring of vision, epigastric pain, headache, nausea, vomiting. Now out of this 5, the patient generally develops a combination of 2-3. So there will be a cluster of 2-3 symptoms. And in our question paper, patient has got headache also, oliguria also, blurring of vision also. So she is not only preeclampsia, yes, of course preeclampsia, but the better diagnosis is impending eclampsia. It is not eclampsia. Okay, it is not eclampsia yet. Convulsion abhi nahi aaya hai, but now anytime soon the convulsion can happen. Now what will I do? Look at the weeks also, 32 weeks. Now, so whenever we have got a patient of impending eclampsia, okay, is it clear? So this is not preeclampsia only, it is impending eclampsia. What will I do? Now very important, please understand this my dear students, that let the pregnancy be 32 weeks, 34 weeks, 36 weeks or 28 weeks. The answer will not change. This whole topic, understand this preeclampsia, eclampsia. Write one very important mantra I am giving you. Delivery is the definitive treatment. Delivery is the definitive treatment. Please keep this in mind. This is very, very useful to us. Delivery is the definitive treatment. So you'll have to decide whether do I want to wait, do I not wait, when to deliver, what to deliver. Okay. Now please understand this. Sir, baby is only 32 weeks in our question paper. Yes, patient is only 32 weeks. Now, आपने हिंदी पिक्चर में देखा होगा, डॉक्टर लेबर वार्ड के बाहर आता है एंड दैट फेमस आइकॉनिक डायलॉग, हम माँ और बच्चे में से किसी एक को बचा सकते हैं. Have you heard this dialogue? Yes, but thankfully we don't make such movies now, but way before you all were born, 1980, 1990, lots of movies that doctor says कि either I can save the mother or I can save the baby. No, please understand this. In obstetrics, it is always mother first. Why? Because if the mother is there, then पीछे पूरा cricket team आ सकता है. That means she can give as many babies as she wants to give birth afterwards. So first priority is to save the mother. Why I am telling you this, save the mother? So whom to save? Save the mother or the baby? Yes, mother is more important. By chance, if the baby is saved, very good. Okay. So, yes, save the Indian government will say save the tiger, save the leopard, save the cheetah. We doctors will say save the doctors first. Yes, save the doctors, but save the mother first. Now, please understand this, that whenever this impending eclampsia position is reached, or this impending eclampsia stage is reached, that is the last day of the pregnancy. Pregnancy cannot be continued further. So, all those who said wait and watch, jail. You have to go to jail. Jail matlab crime. It is a crime. Okay. You will be punished because if you wait, what will happen? If on an impending eclampsia you wait, sir, mother will develop eclampsia, mother will get convulsion, mother will die, baby will die. So never wait and watch. Is this understood to all of you? So you are not going to wait. Okay. So impending eclampsia, never wait and watch. That's the first important rule. And whenever this impending, okay, please understand this, I'm not talking of a controlled preeclampsia. Please comment in the chat box, controlled preeclampsia, when will I deliver? If it's a controlled preeclampsia, if all these things are not given, headache, oliguria, blurring of vision, all that is not given, if it's not eclampsia, if it's a controlled preeclampsia, answer is completely different. Here this is impending eclampsia. Yes, we will have to go and do the delivery, but before I do the delivery, we will also give magnesium sulfate. Now here the patient has not got eclampsia. Yes, here I am giving magnesium sulfate prophylactically. Yes, Please comment in the chat box what is the loading dose of magnesium sulfate what we give, and what is the therapeutic range of magnesium sulfate to be achieved. What level? What is the therapeutic range of magnesium sulfate? Anybody? 4 to 7, 8 to 10 milliequivalents, 10, 14, 15 milliequivalents per liter. How much? Okay, so we will give magnesium sulfate. Now here, sir, patient has not got convulsion. Yes, so we are giving prophylactic magnesium sulfate. This is prophylactic to prevent convulsion. And again, after giving magnesium sulfate, you cannot wait and watch. बात समझ में आ रहा है? You cannot say, oh, I give max sulf, very good, now let me deliver at 37, 38, 39 weeks. No, of course, labetalol antihypertensives will also be given, and this has to be followed by delivery. Most important words coming in the bracket, the delivery has to be done irrespective of weeks of gestation. Please put 3 stars, 5 stars around this line, irrespective of weeks of gestation. Is it clear? So magnesium sulfate, very good, but then deliver at 37 weeks. Sorry, you cannot wait from 30 to 5 weeks. You cannot wait. Again, jail. You'll have to go to jail. Similarly, start labetalol and deliver at 37. No. Magnesium sulfate, yes. Labetalol to control BP, and immediately we will do the induction of labor. When I say delivery, yes, we will induce the labor and plan the delivery. If after inducing labor, we are not having a delivery, then if you do LSCS, all that is okay, but first we can try vaginal delivery. So we can try, or we should do induction of labor first. Is this understood to all of you? So please understand this, never wait and watch. Immediate delivery has to be done. Magnesium sulfate prophylactically, you will comment what is the loading dose and comment what is the therapeutic range of magnesium sulfate. Labetalol to control the blood pressure, and induction of labor or delivery has to be attempted immediately, irrespective. So here let the patient be 32 weeks. If they change the question and make the question 28 weeks, 26 weeks, 24 weeks, the answer will not change. Is this understood to all of you? Yes, sir. But a 24 weeks baby, if I do the delivery, the baby will not survive. Yes, correct. Baby will not survive, but माँ और बच्चे में से माँ को बचाना है. Yes, mother is more important. If I can save the baby, okay. If I cannot save the baby, sad, unfortunate, but then she can try again next time. So let this be 32, 36. Answer will not change whatever may be the weeks. That's what I told you over here. Whatever may be the weeks, the answer will not change. Irrespective of weeks of gestation, the delivery has to be done. Why? Because delivery is the definitive treatment. Third most important topic, or a very important topic, trisomy 21. You should know everything. That is, I mean, antenatal detection of trisomy 21, antenatally trisomy 21 detection, how we are going to do, what are the screening test, confirmatory test. So the question is, patient has come to us at 16 weeks of pregnancy, again a clinical case, for advice for trisomy 21 screening. She's asking your advice, all other screening tests used in the second trimester for aneuploidy except, again, except, do not forget. Okay, so now anybody at 16 weeks of gestation in the second trimester, what is one of the screening tests? It's a triple marker test. What does it have? HCG, alpha fetoprotein, and unconjugated estriol, not estradiol. Okay, clap if you feel happy. यहाँ पे triple marker test है. It's a triple marker test, so 3 markers, and therefore here also you have E3. This is in unconjugated estriol. Okay, what happens in case if the baby is having trisomy 21, HCG is higher than normal and other two are lower than normal. So एक के ऊपर एक MCQ free. And quadruple marker test is also done between 16 to 18 weeks. What is quadruple marker test? Yes, sir. The first 3 are the same: HCG, alpha fetoprotein, unconjugated estriol, and the fourth component or the fourth marker done is inhibin A. Inhibin A is also higher than normal. So in case if inhibin A is higher than normal, HCG higher than normal, other two lower than normal, then there's a risk or there's a chance that the baby may have Down syndrome. It's not confirmatory. Please comment, what will I do next? If the triple marker test or quadruple marker test is showing high risk for trisomy 21, what do we do next? Please comment in the chat box. Do we proceed for MTP? What do we do next? Okay, what is to be done? Please comment in the chat box. Do we confirm it or we directly proceed for MTP? Please let me know. I'll answer you over there. Okay, and the question is that all are to be done in second trimester except. So we can see, yes, PAP A. Anybody? Sir, PAP A is a part of dual marker test, and dual marker test is done in the first trimester. What is dual marker test? Yes, sir. HCG is in all the tests. So, sir, HCG is also in first and HCG is in second also. So, HCG and PAP A. Okay, and please comment in the chat box what happens to the PAP A values. HCG will be higher than normal only. Common sense. HCG यहाँ पे भी high है. In triple, quadruple, HCG is high. So in dual also HCG would be higher than normal. PAP A, please comment. Please comment in the chat box what happens to the PAP A values, whether the arrow is up or arrow is down. So please understand this. All are done in the second trimester except. So alpha fetoprotein inhibin definitely done second trimester. Yes, sir. HCG is done in first and second. So it is done in second. Okay, HCG is a part of double and triple. So PAP A is the best answer, or clear cut PAP A is the answer, because PAP A is done only in the first trimester. Is this understood to all of you? PAP A done in first trimester. Please comment if the values are higher or lower. It is suggestive of Down syndrome. Please understand this. All these are screening tests. Okay, confirmatory test is by karyotyping. Karyotyping is confirmatory test. Okay, confirmatory test is karyotyping. Is this understood to all of you? The next important topic, I am not telling you the topic first, ulta first. We'll see the question so that you can identify, because if I give the topic, you will not be able to, it's the diagnosis out. Okay, so patient has come to us with 2 months amenorrhea. Uterus में ultrasonography, uterus is empty. Okay, right sided mass is felt, size देखना, beta HCG positive. So what is this, my dear student? She is not only 2 months amenorrhea, she is 2 months pregnancy. As you read the question, आगे आगे पता चलता है कि पहले सिर्फ amenorrhea था, फिर beta HCG positive आ गया है. Pulse very good, 80 BP, 120, 80, BP, hemoglobin 11, absolutely. What modality is the most suitable for her? First, anybody, what is the diagnosis? So, my dear student, whenever the beta HCG is positive, that means there is pregnancy. And when we do sonography, uterus mein nothing is seen. That's written over here. Uterus empty. So that is the clue that, sir, if the uterus is empty, the doctor or the gynec radiologist, we should see something outside the uterus. Okay, yes, sir. Okay, sir, outside the uterus, on the right side, whatever. Okay, on the right side, there is a 2.5 by 3 centimeter, means one side 2.5, one side 3 centimeter mass. And what is this mass which is HCG positivity? Yes, this is, so whenever, my dear student, if the HCG is positive, there is a mass outside the uterus and uterus is empty, it is ectopic pregnancy, but not ruptured, because in ruptured the patient, is the patient in shock? No, so patient is stable, and therefore my complete diagnosis, unruptured ectopic pregnancy. Is this understood to all of you? It is an unruptured ectopic pregnancy. Now again, those who want to wait and watch, jail. You'll have to go to, if on ectopic pregnancy you wait and watch, jail. Jail matlab it's a crime. It's a criminal. Okay, similarly, if you repeat USG after 2 weeks, in that 2 weeks, the ectopic will rupture, patient can die, again you'll have to go to jail. Okay, is this understood to all of you? So please, students tell me, sir, we remember all these words in the exam, and my dear student, you'll remember all this in the exam. Sir ne bola tha, you'll go to jail, don't do all this. So we are not supposed to wait for 2 weeks. Similarly, you don't wait and watch. Now this is unruptured ectopic, and can you tell me, in unruptured ectopic, methotrexate is always preferred. Methotrexate is preferred provided what are the criterias? Yes, sir. So first of all, it should be a unruptured ectopic pregnancy. That means the patient should be stable. Look at it, our patient is stable. Second, very important PYQ, the sac should be less than 4 centimeter, which is our case. We have got around 3 centimeter ka sac. You can see the pregnancy, the right adencyal mass of 2.5. Don't multiply this 2.5 into 3, huh? 2.5, 2.5, 2.5. Multiply nahi karna hai. 2.5 into 3 means, sir, one side is 2.5, one side is 3. It's almost like 3 centimeter. Okay. So yes, and patient should be stable. Sac should be less than 4 centimeter. Preferably the fetal cardiac activity should be absent, preferably, and most importantly, beta HCG less than 5000. And look at our beta HCG level, it is 1500. So can I give methotrexate? Yes, sir. With beta HCG of 1500, less than 5000 micro international units per ml, all these criteria are satisfied, and therefore no need to do a surgery. Okay, surgery or a laparotomy would be done mainly for ruptured ectopic pregnancy, and the patient has come to us in shock. If they tell you patient BP 90/60, hemoglobin 6, then immediately IV fluids cross match and ruptured ectopic, shock may we prefer to do laparotomy. Okay, so the answer over here is methotrexate. And again, please comment in the chat box, after giving methotrexate injection intramuscular, how do I know my treatment is working or not? What do we monitor? Anybody, what hormones we check? What level should drop and what should happen? So please comment in the chat box that what is monitored after giving the methotrexate injection for unruptured ectopic. And that was our topic number 4, ectopic pregnancy. I didn't want to show it before, otherwise this diagnosis clinical case would have been giving away the answer. So the diagnosis is unruptured ectopic pregnancy. Next very important topic, instrumental deliveries. By that I mean forceps and vacuum, when to apply, what is to be done, all that. So let us have a look at the question. New pattern. Now please understand this new pattern MCQ. So this video very important. I will discuss not only images, new pattern. What is this new pattern? Directly question come, students start marking 1, 2, 3. No, please understand this. The question starts from select the correct answers using the code given below. So first, what is the question? Indications as well as prerequisite for delivery with ventouse. Ventouse is same as vacuum. So the question asked to us is, what are the indications for vacuum? What are the prerequisites for vacuum delivery? Include which of the following? 4 scenarios are given to us. Okay, so point number one, clap if you feel happy, thoko tali. Vacuum is only for vertex presentation. V for vacuum, V for vertex. Why? So if it's a face, अगर face है, I apply vacuum, eyeballs will pop out, आँख बाहर आ जाएगा. So face presentation, I cannot apply vacuum. Similarly, if the baby's bump, I can only see the baby's bump. If it's a breech, okay, तो baby का bump पे I can apply vacuum. Okay, कहाँ लगाएंगे vacuum? Baby का bump पे? No. Okay, so again for breech also vacuum cannot be applied. So please understand this, that's a vacuum application cannot be done on face, cannot be done on breech. It has to be a vertex. So vertex presentation, yes, very good. Now, what is the other thing? When do we apply a vacuum? Okay, so point number 1, vacuum is applied when one is maternal exhaustion. Mother is exhausted, mother is pushing, mother is not able to push the baby out, maternal exhaustion. Okay. Or second, if it's a prolonged, same thing, prolonged second stage, mother is pushing 2 hours, 3 hours for prolonged second stage, baby is not coming out. Is understood to all of you? And if it is also fetal distress, yes, in fetal distress forceps is preferred because forceps is faster, but even in fetal distress also we can apply. Okay. And I want to cut short, like certain cases like there is heart disease, all that, we don't want the mother to do too much pushing, bearing down. So I want to cut short second stage of labor, cut short second stage. Okay. Is this understood to all of you? Is it understood to all of you? So, point number 1, yes, delay in the second stage of labor. I told you, prolonged second stage. Fetal distress, how do I know? Yes, sir, fetal distress, non-reassuring fetal heart rate. And cut short second stage. But remember, very important, like how it should be vertex, it should also be one more, pelvis should be adequate. Very important point. There should be no cephalopelvic disproportion. And the most important, prematurity is a absolute contraindication. Why? Because, sir, prematurity is a absolute contraindication. Why? Because, sir, if preterm babies are anyway more prone to intraventricular hemorrhage, and when I apply a vacuum in a preterm, there's more chance of intraventricular hemorrhage. So in a preterm baby, I will never apply a vacuum. Is this understood? Prematurity, absolute contraindication for vacuum. Forceps can be applied. Okay. So for vacuum. Okay. So for vacuum, absolute contraindication is prematurity. Very important. There should be no CPD, pelvis should be adequate, and vertex hona hi chahiye. And that is it. Gestational age less than 34 weeks. It's not a indication and prerequisite. This is a absolute contraindication. So now यहाँ से choose करना है, 3 नहीं हो, 1, 2, 3, no. 3 out, yes, 1, 2 and 4. 1, prolonged second stage or delay in the second stage, fetal distress, and vertex presentation 1, 2, 4. So I hope you like this new kind. Don't panic. The new style of MCQ. Don't panic, but these questions have started coming. So number 3 is out. So jahan pe number 3 hai, those automatically out, and option number 2 is the answer. Is this understood to all of you? And also, my dear students, go and check out the 70-day timetable strategy video. I already put it on the YouTube. All of you can have a look at it and look at this beautiful colored notes. My dear student, every student has told me that, sir, once we have seen your videos, we can revise the entire notes just in 2 to 3 hours time. And all of you, please understand this, OBGY is a major subject. 30 to 35 MCQs are going to come, and so many students, sir, you can read the reviews, the videos are pure magic, absolutely crystal clear concepts. I could score so high. So many students, they get stuck up at the score of 130, 140. They were not able to cross 150. And then because of OBGY, sir, OBGY ne bacha liya, because my dear students, whichever source you have studied OBGY from, if with your current knowledge you are getting 10, 11, 12 MCQs correct, then after this rapid revision course, your score is going to jump up and you can get easily 27, 28, 29, 30 MCQs correct in OBGY. So it's an extremely scoring subject. Just give 2 days time. Whichever previously, like this, if this half an hour video has benefited you, imagine when you see only MCQ, it's all the PYQs, all the IBQs, clinical case scenario, virgin MCQs of not only FMG, NEET PG will also be covered. Theory rapid revision videos are also there, and totally exactly in 2 days time you can master OBGY, revise OBGY, and your score is going to jump up from 15, 16, 17 to 27, 28, 29. Minimum 10, 15 marks more you are going to get. And I don't need to tell you the importance of those 15 marks. It's a difference between score of 135 and 150. So many students get stuck at 135, 150. 140, then they take my OBGY. Get in touch with me. Launch 30 is the discount coupon code. Just in 679, under 2 days, you can revise the entire OBGY. Beautiful topic wise MCQ. There is quiz and discussion. You will attempt the test, you will give the quiz, you will attempt, then you will see the beautiful explanatory answers are there, quizzes are there. So please download the OGGURU app, and don't worry, we are going to give you free extension till those students who buy in this week. You will get free extension till 17 Jan. So 2 months validity only at 679, and just in 2 days time, under 2 days, you can master OBGY and revise OBGY. So please share this video with all your friends and colleagues. I'm there to help you and guide you. Follow us on Insta also. Do check out the other videos on YouTube, and all of you will do very well in the upcoming examinations. Here wishing you all the best and best of luck.